Good evening, everyone, and welcome to the next edition of the Image Journal Club. And we are happy to have many of you here eagerly watching this. And today we have Dr. Rizwan to present us on the Journal Club, and followed that we'll have the Eagle Eye competition, the quiz, and the usual protocol. And we have our international journal reviewer, Dr. Chandramouli, who will be giving us the comments after Dr. Rizwan's presentation. Over to Dr. Rizwan.
Good evening. Thank you, sir. Thank you so much for the opportunity. I'll just share my screen. Is it visible?
Yes, sir. Just put it. Yes, it is visible, sir. Please go ahead.
So today's journal club topic is master study. So master stands for monoclonal antibody-based sequential therapy for deep remission, which this particular paper which we are discussing is actually a long-term follow-up of the master study, which was published in JCO in 2021. So the initial follow-up was of like 25 months, and this is an updated follow-up of 42 months, which we'll be discussing today. So the flow of agenda would be, we'll have some discussion on MRD in multiple myeloma, LEN maintenance and quadruplet induction with MRD monitoring, followed by the study paper discussion of methods, results discussion, and future prospects. So the master study was actually conceptualized by Costa in 2016 when the data started coming up of daratumumab with deeper remission. And at the same time, there was data that MRD can be prognostic in multiple myeloma as well. So the question was that whether MRD-directed therapy in multiple myeloma can lead to treatment-free remission with MRD monitoring. So a few things about MRD in multiple myeloma. So it can be measured by two methods, either NGS or flow cytometry. Flow cytometry, we are commonly aware, it uses cell surface or cytoplasmic antigen, and we don't require a baseline sample to run it. It has to be run via Euroflow protocol, which includes two tubes. Each should be able to give around 10 million events, and it has to be run on an 8-color multi-para flow cytometer. And the maximum sensitivity is around 2 × 10⁻⁶ if run via Euroflow protocol with 20 million events. Coming to NGS, NGS is based on sequencing of heavy chains and light chains, and we do require a baseline sample in order to track that clone. The method used in this study is a clonoSEQ, which is made by Adaptive Biotechnologies. And only 2 million cells can give us a sensitivity of 6.8 × 10⁻⁷, or roughly around 20 picogram of DNA. So a less amount of sample, around 3 ml of bone marrow sample will be able to give us this high sensitivity as compared to much large amount of sample required in flow cytometry. Now, before we delve further, we need to know about three terms. One is limit of blank, limit of detection, and limit of quantification. So limit of blank is the highest number of aberrant events that can be measured in a negative sample. So it's closest to zero. So the test is not able to find out if it is there or it's not there, right? That's limit of blank. Limit of detection is when it refers to the lowest number of malignant plasma cells that can be reliably detected. Okay. And the limit of quantification is whose frequency can the sequence can be quantitatively determined. This is important because FDA has mandated that any MRD-based multiple myeloma studies need to have their MRD test, LOD, and LOQ quantified beforehand. So in this study, we have used clonoSEQ. So for clonoSEQ, at an input of 20 picogram of DNA or 2 million cells, the LOD is 7 × 10⁻⁷, and LOQ is around 1.8 × 10⁻⁶. However, as FDA mandates, the detection threshold of MRD assay should be at least 10-fold below the clinical decision-making threshold. So if the test can go up to 10⁻⁷, then we need to use 10⁻⁶ to make a clinical decision in the trial. However, in master study, they have used a cutoff of 10⁻⁵, just because this was the first trial wherein they were using MRD to actually modulate or change the therapy and decide the therapy. So it was a crucial decision. So they tended to use 10⁻⁷ just to have more accuracy and precision. Now, these is all about the lab. However, whether that actually lab values do translate to any clinical outcomes. So for that, there was this paper which is published by Nikhil Munshi and group, This was published in Blood Advances, I think 2 years ago. So it was a meta-analysis with around 8,000 patients for which they analyzed the PFS into across multiple trials. It included patients of newly diagnosed multiple myeloma who were transplant eligible, and as well as transplant ineligible population, and relapse refractory population and undefined population. In almost all the subgroups and all the studies, we can see that MRD negative patients tend to do better with a hazard ratio of 0.33. Coming to OS analysis, in this study, they have used around 4,297 patients across multiple studies, again, transplant eligible population, transplant ineligible population, and relapse refractory population. And we can see that in all the studies with patients for MRD negative, they tended to do better with a hazard ratio of 0.45. Now, coming to the other question of LEN maintenance. So LEN maintenance was used indefinitely and is currently being used indefinitely or up to a period of time after transplant, because we've been using triplet or doublet or triplet induction therapy. Now, this is a meta-analysis of LEN maintenance after transplant. And this analyzed patients across 3 studies, the CALGB, the IFM, and the GMEMA studies. And across all these 3 studies, it showed that if you continue LEN maintenance, the patients tend to do better. And this is the PFS curve, which is showing that if the patients were on LEN maintenance, they tended to do better with a hazard ratio of 0.48 as compared to when they were not. And this included all subgroups of patients across ages, sex, risk stratification, as well as transplant. All of these favored LEN maintenance. Coming to the OS analysis of this meta-analysis, and again, it also showed OS benefit with the hazard ratio of around 0.75. And again, it was across the ages and across the treatment strategies used and across all the 3 trials. Now, what happens when we use a quadruplet induction upfront? So we've discussed about the triplet induction, and now we'll discuss about the quadruplet induction. So if you use quadruplet induction like Dara-VTD as it was used in Cassiopeia study, and if the patients were kept on observation or on maintenance Dara, and if they achieved MRD negativity up to 10 to the power minus 6, then which they can achieve whether they were on Dara maintenance or on observation, this is not statistically significant as to 0.1037, then the outcome is not statistically different. So in the patients of Dara-VTD followed by Dara maintenance and Dara-VTD followed by Dara observation, the hazard ratio was 1.02 with p-value of 0.91. So it was not significantly different if the patients who have received a quadruplet induction and were MRD negative, whether they were on Dara maintenance or they were on observation. So the important takeaways from the discussions which we have done so far is that Dara-VTD arm patients achieve higher rates of MRD negativity when compared to non-Dara based treatment regimens. I mean to say quadruplet regimens. And if you look at MRD negativity, sustained MRD negativity means 2 different time points around 1 year apart. So if the patients who were in sustained MRD negativity tend to do better regardless of treatment. So if the patients have sustained MRD negativity for 2 years, they tend to do much more better than the patients who don't. Also, if you look at the Cassiopeia study from a different angle, if you see Dara maintenance for 2 years, it reduces the risk of relapse and death amongst almost 70% of the participants who were not previously treated with Dara. However, if you look at the observation, it also highlights that favorable outcomes were seen in patients treated with quadruplet induction and consolidation and without any maintenance therapy. So this also illustrates one more thing, that the maintenance therapy has an effect, and the effect what it is going to have will depend on the induction and consolidation therapy. Now coming to our study, which we are discussing today. So master study is a single arm phase 2 study, which included 123 patients. It was a multi-center study at 5 sites in the US. It was enrolled patients with newly diagnosed multiple myeloma of more than 18 years of age, and it did not have any upper limit for age. It's very important. And they also allow something called pre-treatment up to 1 cycle of Cybody in the treatment arm. So if you compare this with the Griffin study, so the screening time for Griffin study was around 3 weeks. So all the patients who were sick, they could not be enrolled in the Griffin study. Wherein in master study, they allowed emergency treatment with steroids, with Cybody, 1 cycle, patients with renal impairment. so that patients who has a poor PFS or has renal abnormality improves after CyBody and was eligible to be enrolled in the master study. So this is one of the important aspects. So this is really an innovative trial we've seen in, I think, last 5-10 years from myeloma point of view. Also, for the organ function, it needed to have a creatinine clearance of around more than 40, and ALT, AST should be less than 3.5 upper limit normal, and bilirubin was supposed to be less than 2. Patients who were having infections, pregnancy, or second malignancies were excluded from the study. Even patients diagnosed with concomitant POEMs, amyloidosis, or Waldenström's were excluded. The other important thing about this study is that they have mandated as a part of the protocol to have at least 35% of the participants who would have high-risk chromosomal abnormalities. It's a very contrasting thing when you compare it with Cassiopea study, which had actually less than 10% of the patients with double hit multiple myeloma. So the idea of the study is that we'll do a quadruplet induction and achieve MRD negativity. And if they are persistently MRD negative, whether can we have treatment-free remission or not. However, when you look at the objectives, as mentioned, the supplementary of the protocol, the primary objective of the study as defined is actually to assess the MRD negativity achieved after quadruplet induction. The secondary objectives include the toxicity profile, finding out patients who have achieved imaging plus MRD negativity, the frequency of MRD after induction therapy, and frequency of conversions of MRD positive to MRD negative post-transplant or post-consolidation therapy, and the patients who have achieved CR with MRD negativity. However, the most important objective, I think, is the feasibility and effectiveness of MRD-guided treatment discontinuation in newly diagnosed patients who have confirmed MRD negativity. And if those patients are on observation, then what is the risk and timing of the resurgence of MRD after discontinuation of therapy? So this is the study design. So newly diagnosed multiple myeloma transplant eligible patients were included, 123 of them, and they received Dara-KRD with the standard dosing, except the fact that Carfil was given at 20 mg per meter square on the first day of cycle 1. After that, they received at 56 mg per meter square. Darzalex was given at 16 mg per meter square, the standard dosing, which we give weekly for like 2 months, and followed by the 9th dose also weekly, and then every 15 days for cycle 3 and 4. Len was given at 25%. They have done some dose reduction, which we'll discuss later on. And Dexa was given at 40 mg 40 mg at weekly dosing. So after 4 cycles of Dara-KRD induction, they underwent an MRD assessment by NGS and proceeded for a bone marrow transplant. They used Melphalan 200. In some cases, 140 was used in the protocol, but exactly what was the indication why it was used was not, I could not find out in the supplementary. And post-transplant at around day 60 to day 19, between that, they did a second MRD. And if you are 2 consecutive MRD negative, for example, this and this, if you are MRD negative, then you can proceed to something called as MRD sure phase of the study, which is treatment-free observation and surveillance. Now, if you are still MRD positive, you go with consolidation 1, that is 4 cycles of Dara-KRD again, and then again repeat an MRD. And if you are negative, then you proceed to the treatment-free phase. If you are positive from here, you proceed to another cycle of consolidation, which again consists of 4 cycles of Dara-KRD. And then again MRD is tested. And if your MRD again negative here, as in 2 consecutive, so either these 2 or these 2 or these 2, consecutive MRD negativity should be there in order to proceed to MRD sure phase. If it is MRD positive, then at this time point, then they proceed for Len maintenance. In the protocol, they've mentioned that the MRD assessment was actually done in between the Dara-KRD consolidation. So it was done 2 cycles. So at cycle 6 and cycle 10. So after 2 cycles, they have done somewhere in between. And then here also they have done somewhere in between. So not at the end actually as depicted in the picture. So this is the baseline characteristics of the patients. One of the important things is that around 20% of them were more than 70 years of age. And the other important striking feature is that almost 20%, 21% of them had a deletion 17p. And gain or amplification 1Q was present in almost 36% of the population. And most of them, I think, were balanced between the standard and high-risk groups. Now, the results of the study. So if you look at the MRD negativity at the rate of 10 raised to minus 5, so in the entire cohort, I think 81% of the patients were achieved MRD at any one point of the therapy. And if you stratify it as per high risk abnormalities, one high risk abnormalities or two or more high risk abnormalities, then 78% of them achieved in patients who did not have any high risk features, 86% in those who had one high risk feature, and 79% in those who had two or more high risk features. Now, CR plus MRD negativity. So it can be possible that a patient is not in CR, like in VGPR, and still has MRD negativity. So this can be because of 7 reasons, which is listed in one of the papers published in Blood, which actually designates that one of the reasons could be that the MRD protein clearance is a little slow because the creatinine is deranged and the kidneys are not functioning well. But there can be some sampling error, and it's a big discussion actually. So I won't go there as to why patients can have a lower level of IMWG response like VGPR and still have MRD negativity. So, however, we'll discuss that CR plus MRD negativity was achieved in 72% of the patients overall, and 76% with no abnormalities, 75% in with one abnormality, and 58% with two or more abnormalities. Now, coming to this is the exploratory analysis, that is MRD negativity at the power of 10⁻⁶. In this, almost 71% achieved this level of MRD negativity, with 68% in no high risk abnormalities, 80% in with one high risk abnormalities, and 63% in two or more high risk abnormalities. Now, coming to the cohort which actually achieved 2 consecutive MRD negativity and went into the MRD sure phase of the study. So almost 71% of the total patients, that is 84 patients, were able to meet this criteria of achieving 2 consecutive MRD negativity and were shifted to the MRD sure phase. When you stratify them into sub-analysis, then 66% of them were from the patients who had no abnormalities, no high-risk abnormalities, and 82% with one high-risk abnormality, and 63% of the patients were those who had 2 or more high-risk abnormalities. In the end, around 20% of the patients proceeded with LEN maintenance. To summarize, if you look at this this trial design, so 20 patients in the end were here and who went to LEN maintenance, and the rest, around 70% of them were able to achieve MRD sure phase. Now, another thing is sustained MRD negativity. So the trial defined consecutive MRD negativity, but the actual sustained MRD negativity is something that you have 2 different time points separated by 1 year apart, wherein there is sustained MRD negativity. So that was achieved in 64% of the patients who had no high-risk abnormalities, 73% of the patients who have one high-risk chromosomal abnormality, and 46% of the patients who had 2 or more high-risk chromosomal abnormalities. So if we look at the achievement of MRD rates all throughout in different subgroups, they are not very different when you look at look at the first 2 groups, like when they don't have any abnormality or they have one abnormality. So it seems that quadruplet induction is able to conquer or get through that one high-risk abnormality. Coming to the survival analysis, so this is the PFS, 36-month PFS. So it is this is the Kaplan-Meier curve. The red one is for no high-risk abnormality, so that is around 88%. The blue curve here depicts the patients survival of patients who have one high-risk cytogenetic abnormality, and that is around 79%, and at around 3-year time point. And patients who had 2 or more chromosomal abnormalities, high-risk chromosomal abnormalities, so for them around 50% is the 3-year PFS. Coming to the patients on who, or the subgroup of patients who actually progressed on therapy. So these are 6 patients who had disease progression while on therapy. So one of them was during induction, one after transplant, and which was just before consolidation, and 4 happened during consolidation therapy. And all of these patients had 1Q gain or 1Q amplification. However, they have not differentiated in the manuscript as to how many patients were 1Q amplification and how many of them were 1Q gain. And 5 of them had deletion 17p, and 5 had 2 or more high-risk cytogenetic abnormalities. And all of them, in spite of being using salvage regimens like CAR T cell therapy and BCMA-directed therapies, the maximum survival of all those patients who progressed on therapy was only 10.8 months. Coming to the overall survival analysis, so 3-year overall survival in the patients who had no cytogenetic abnormality, the red curve is around 94%, and it is around 92% in the patients who have one abnormality, that is the blue curve, and 75% in the patient who have 2 or more high-risk cytogenetic abnormalities. So we see that the outcome is still not as good as for these patients who have 2 or more cytogenetic abnormalities as compared to the patients in the first and second group, that is without any abnormality and one, and there's no statistically significant difference in their outcomes. However, when we compare the patients who have 2 or more abnormalities as compared to none, then there is a significant difference between the outcomes of overall survival of these patients. So how many patients died? So 15 patients died. 3 died during therapy. Now here it is interesting that they have reported 2 sudden deaths here, and they have not mentioned whether it is cardiac or non-cardiac. I think this is relevant because the patient was on carfilzomib-based therapy, and this should have been mentioned in the adverse event profile. However, and another 3 deaths happened after therapy and while on MRD SURE based surveillance. In those patients, there was no disease progression. But again, here there was 1 sudden death reported and 1 from COVID-19 pneumonia and 1 from accidental fall. And they did not report any deaths occurring because of the therapy. 9 died because of the progression of multiple myeloma. 6 whose myeloma progressed while they were receiving protocol-directed therapy, and 3 with disease progression after completion of therapy. Now, this is another interesting thing. So what they have done is they have shown that if MRD is positive after induction or after transplant, and because we are giving KRD consolidation in transplant, we are able to overcome the negativity of the early MRD positivity. So what they have told that if you are MRD positive or negative, but at the earlier stages of treatment, like post-induction or post-consolidation, they don't tend to have a significantly worse outcome in your overall as an overall analysis. So as you can see, there is a p-value of 0.94 and 0.11. The other thing which they have assessed is the 3-year PFS in patients who have sustained MRD negativity and those who don't have it. So the patients who had sustained MRD negativity had 3-year PFS of 89%. So those who did not have the sustained MRD negativity, the PFS was around 55%. And this is valid at 10⁻⁵ and 10⁻⁶ levels. Now, coming to the patients who actually went on to the surveillance, so 84 participants transitioned into MRD SURE phase, and out of that, 27% of the patient resumed therapy. So almost 1/4, you can say, of them resumed therapy because of MRD resurgence or disease progression. And all of them, 52%, that 61 participants, that is 52% of all the patients, and 73% of the 84 patients who actually transitioned to MRD SURE did not receive any further therapy. So they actually went to MRD SURE and did not require any further therapy for multiple myeloma during the period of median follow-up of 42 months, right? So if you can assess into real numbers, then you can say that half of the patients can actually get away without getting further therapy, at least for the median follow-up of 42 months, according to this study. So if you look at the 3-year PFS of patients who actually went on to MRD SURE phase, was around 80, this red curve, that is around 88% with no abnormalities, and 85% with 1 chromosomal abnormality, and 60% for those who had 2 or more high-risk chromosomal abnormalities. Coming to the OS, the 36-month overall survival was 97%. For no high-risk abnormalities, 93%. For those with 1 high-risk abnormality, 100% for those with 2 or more high-risk abnormalities. I think this requires a closer follow-up and a longer follow-up because 100% patients are not doing as good. But however, these are the patients who achieve consecutive MRD negativity. So they might be those subgroups of the patients with 2 or more abnormalities who tend to do better. Now coming to the tolerability of this regimen. So almost all patients had some or the other form of adverse events. And the most common adverse event was fatigue, bone pain, neutropenia, and rash. And the most common serious event was pneumonia, which happened in around 8 patients, and thromboembolic events, which happened in around 3 patients. 1 patient also developed metastatic colon adenocarcinoma when the patient was on lenalidomide, but it is mentioned that the patient was off protocol, but there's no other clarification given. And no other patient developed any secondary malignancies. Now the dose reduction, so carfilzomib, around 12% of the participants required dose reduction for carfilzomib. And for Len, around 59% of the participants, like 72 patients, required dose reduction. And for DEXA, around 41% of the participants required dose reduction. Now coming to drug discontinuation. So 2 patients actually discontinued the drug because of the grade 4 HUS and grade 3 abdominal pain. Whereas Len, 1 patient also discontinued therapy because of 2 patients actually, grade 4 thromboembolic event and 1 for peripheral neuropathy. So coming to discussion, I think what we can learn from this study is that no high-risk chromosomal abnormality patients and with 1 high-risk chromosomal abnormal patients tend to do almost equally when treated with quadruplet regimen with MRD monitoring. The problem we have in India is that we don't have clonoSEQ, so we don't know whether the MRD which we are checking is actually validated. The other option is there is a lab which actually sends the sample from India to clonoSEQ, but it is kind of costly for our patients. So if you look at the master study, 82% of the patients reach MRD negativity and 73% achieve like 10 raised to power minus 6 negativity. And also 73 had like consecutive MRD negativity and they were able to enter MRD sure. Which is actually not very different if you compare it to Cassiopeia study, which was a similar, like that one arm, if you consider of that study, a DARA-BTD induction followed by transplant, followed by DARA-BTD consolidation, and then either no maintenance or DARA maintenance. So if the patient was in no maintenance with MRD negativity, so this is another study which was like quadruplet regimen followed by transplant, followed by MRD monitoring, and the patients tend to do better with this regimen if they are MRD negative. Now coming to Griffin study, it is a similar study with DARA-VRD. And in this study also, patients really did well after and achieved MRD negativity when compared to triplet regimens. However, if you look at these data, they do indicate that relapses happen while on protocol also, like in Griffin trial as well as in our master study. So these are the patients who would not do well otherwise also. So those, if you look at the survival of the patients who actually survived after master study, who were relapsed on study protocol, the maximum survival is 10 months and the minimum is around 1 month. So I don't think these are the patients who would, I think, require different kind of strategies. The only study which has a better outcome for the patients who have like 2 different high-risk abnormalities is the Optimum study. But Optimum study also used SKY92 as one of the risk stratification tool, like the gene expression profiling. So currently, if you say the author's conclusion was that it's not that we can give treatment-free remission for patients who have 2 or more abnormalities, because the PF is around 50% and OS is 75. However, we need, I think, better treatment modalities for these set of patients. But if you look at it, then more than 80% of the patients who are newly diagnosed will not belong to this group. So for those patients, I think half of them can be taken up and given MRD-free remission, at least for the amount of follow-up we have. So coming to the future prospects, so where it is going, so the Master 2 study is planned, it's enrolling. The Master 2 study is another study which has like 6 cycles of DARA-VRD and then MRD randomization based on MRD. So if the patients have MRD negativity, they are taken to 2 arms, arm A and arm B. So arm A is 3 cycles of DARA-VRD followed by 13 cycles of DARA-R. And arm B is transplant followed by 13 cycles of DARA-R. The question they are asking here is whether transplant can be replaced by 3 cycles of DARA-VRD. The patient is MRD negativity after 6 cycles of DARA-VRD. Now coming to patients who will be MRD positive. So those patients will receive a transplant followed by 3 cycles of DARA teclistamab consolidation and 13 cycles of DARA teclistamab maintenance. And arm D, wherein the ASCT followed by DARA-R consolidation and 13 cycles of DARA-R maintenance. So the question they are asking is the patients who are biologically tough to treat, like who are MRD positive, whether any strategy like bispecific could be of any help in this case. Another very interesting thing which is coming up is the role of immune surveillance in MRD negative patients, because as we know, if the patients are the thing that works is actually immune mediated surveillance of tumors. So if we in patients who already have MRD negativity, so whether we can use immune surveillance as a mechanism to actually predict the relapse and monitor them. I think that's all from me. Thank you so much for the opportunity. Thank you so much.
Thank you very much, Dr. Rizwan, for that brilliant disposition of that paper. Very well analyzed, I must say. I would request Dr. Chandramouli Nagarajan to kindly share his thoughts, and after that, I'll share my thoughts.
Yeah, indeed. Very well presented, Dr. Rizwan.
Thank you.
Even some of the issues, intricacies in this trial that I did not know, I learned today. First of all, I think some basic comments about the study and its relevance for today's practice, right? So it is, at the end of the day, a single arm phase 2 study. So you see a lot of these quadruplets, particularly either quadruplets or triplets based on the backbone of using carfilzomib in first line. I'm not sure what is the reason for many of these combinations coming up, because there is no country where carfilzomib is approved upfront for the use of newly diagnosed myeloma patients. So I'm not sure who is going to use carfilzomib in the front line unless you have a patient who really cannot tolerate bortezomib, because at the end of the day, simple as it might be, bortezomib is a very effective drug, particularly when you combine it with immunomodulatory drugs and our CD38 antibodies. So, relevance is something that we need to, bear in mind, not just for the point of doing trials, but how are we going to use that data to drive our clinical practice. But of course, there's no two ways about it. The trial was very brave and bold in the way it was organized and run at a time when MRD was just assuming importance. And it asks a crucial question. One of the key tenets, if you listen to Luciano in the talks, is the question that many of our patients have in our clinics. When can I stop therapy, especially in the newly diagnosed setting, when they start their induction consolidation, and especially in a transplant setting, when can they stop therapy? So that's one of the key things that they are set out to answer that question. And I think to some degree they have answered it successfully. Not that we're going to use MRD and suddenly stop treatment. And as I mentioned, this is a single arm study. We need to be showing clearly in a sustained regular MRD monitoring way what are the drugs that are going to go into the composition to allow patients to have a fixed duration of treatment when we employ transplant as a part of the induction consolidation strategy, and who are these patients who can be off therapy. But I do think that they possibly missed a trick or two, and I would want Dr. Rizwan to answer a couple of questions, whether they have mentioned it. One, I don't think, and I have never heard Luciano say this, for the patients who had MRD resurgence, meaning that they were too MRD negative initially at some phase, and then went into the MRD sure phase, and then they subsequently had a positive MRD. So by protocol, if they had a relapse that fits into the definition of IMWG definition of disease progression, of course, they need to be taken off protocol and switched to a second line treatment. But for patients who had only MRD resurgence, how were they treated? Do they go on to another line of therapy?
Hello, can you hear me?
Yeah.
Yeah.
Go ahead, Rizwan.
Yeah, so they have mentioned a table in which in the supplementary where they have mentioned as to what were the treatment regimen used for those patients, and it is not a standard regimen. If you look at that table, so patients have been treated differently. Some of them have even received bortezomib and doxim. So those actually that entire thing was not standard. Okay, or if they go to off protocol, what was the regimen we used in that
Yeah. So that
setting.
one, I think would have been quite useful to, for example, proof of principle showing that if it is only MRD resurgence, when they're off therapy, whether they could be retreated with the same combination, and showed that they could still be rendered as MRD negative. So that one, we don't have an answer to that question. Second, hello? Yeah, can you hear me?
Sorry, I missed the question. Yeah.
No, so I'm just saying that they haven't showed that whether these patients on MRD resurgence can be retreated with the same regimen and still be rendered MRD negative again. I think that one could have been showed in this trial, which wasn't.
Yeah, this was not short. So the patients were treated with different regimens. I think they were taken off protocol and then treated based on the treating physician. However, they have mentioned in a table that what all has been used. So some of the patients have actually even used CAR T cell therapies and investigate. Some of them have gone to other clinical trials also. So it was not a standard protocol that was followed.
Okay. The other couple of questions I had was, do they mention a cutoff of the 17p or p53 in the cells?
So they have particularly mentioned that in all these abnormalities, we have not used a cutoff to define them. So some of the trials they use like 55% for P53 and all, they have not used. They've mentioned it that they've not used.
Okay. That's fine. I mean, IMWG does have a
Yes,
definition
yes.
of its own, which is 60%, which, to be
Yes,
honest,
yes.
I don't think most trials don't use them. The other question I had was, in each of those response categories that you showed, if you see, what was slightly, striking was the fact that almost in every category of responses, the patients with one high-risk chromosomal abnormality is always better. The proportions are better than patients with even no high-risk chromosomal abnormalities. I don't understand why that is the
Yes,
case.
yes. This is the question even I had, and I couldn't find any answer to this question. But somehow patients with single abnormalities tended to do better in almost like not all, but yeah, in almost all of them, they were having a better rates of MRD negativity.
Now,
I
I
really don't
suspect,
know the
I
answer. I
don't
would
know
love
if
to know,
this is,
but yes.
yeah, carry on.
No, carry on, sir. Just no, I was just mentioning that I also don't know that, and I would love to know. Actually, I was thinking of writing a mail to Lucian for this.
Yeah. No, I suspect it might be because of patients with 414. And, though this is classified as, high risk under the IMWG, we do know that carfilzomib has particularly high efficacy in patients with 414. And I suspect that is probably that, but I don't know if that is really the reason. The other couple of things I mentioned is, do they mention among the 123 patients, did every single one of them have baseline sampling? Because they are using NGS in this study as the main MRD assessment modality.
Yes.
Did anybody miss the baseline sampling, thereby
Five. So 5 patients. So
Five.
5 patients were not having those sampling. Yeah. So 118 patients had evaluable MRDs, and 5 of them did not have. Yeah. And out of that, I think 2 of them went on to LEN maintenance and 1 post-transplant off therapy and some patient-based decision that mentioned like that. But 5 of them did not have an baseline MRD, evaluable MRD. Yeah.
Okay. Yeah. So I think if we take the study as a whole, so what are the key messages that I take away from this trial? I mean, clearly, quadruplets are effective against, as a newly diagnosed myeloma treatment option. Yes, they are very effective. Now, we do know already from many trials, as you showed in that meta-analysis paper from Nikhil, that MRD negativity, deep remissions characterized by MRD or sustained MRD negativity leads to better survival. It doesn't matter how you get those patients to the MRD negativity, as long as you get them there, and more importantly, keep them there, their survival is important. So it doesn't have to be Dara-Chiadi. You can get patients into MRD negative state with the VRD and transplant. I think it's unlikely anything less intense than VRD might significantly compromise your ability, even when you use transplant, to get them into MRD negativity. I think that from all the trials we do know. And this, again, the master trial emphasizes the same point. Now, what I have, and so this is definitely, these 2 points are definitely, shown as a very clear, concept again in this single arm phase 2 study. The third concept probably that first came out of this, even though, they were same time compared to Griffin, for example, Griffin had its own problems, right? In the maintenance phase, there were lots of patients who missed their lenalidomide maintenance. So if you see the PFS curve separating distinctly, this PFS starts separating at the point of maintenance, which, for some reason, the VRD triplet treated patients in Griffin, a lot of them dropped their len maintenance, whereas the Dara VRD patients kept it. I don't understand why. But in this study, at least, clearly, when you drive patients in MRD negativity, even in a patient with 2 high-risk chromosomal abnormality, and you can keep them there, your survival is much, much better. But as you rightly mentioned, the sudden deaths, the patients with, more severe infections and thromboembolic disorders are a point of concern. And I'm not sure, I mean, they use the doses that possibly, we can use on a regular basis. There are some studies, for example, the Manhattan study, which has got a very similar, I think the doses of carfilzomib is much higher. I don't think it is feasible in clinical practice to employ that kind of doses day in and day out to keep patients in MRD negativity. This is a very much doable regimen in that sense, even in a community setting. Just once a week, 56 mg per meter squared carfilzomib, and rightly they did dose reduce, but that was also done in a very clever way, I would say, because they were more happy. If you look at the percentage of dose reductions in the slide that you put it, they were more happy to dose reduce the lenalidomide part of it rather than the carfilzomib part of it. So they did believe much more on the carfilzomib component to drive the patients into remission rather than lenalidomide, which was, I think, a good strategy. And that's probably what I will do as well, to keep the carfilzomib and use maximum benefit being drawn out of that. So that's the third point I'll take from it. Using carfilzomib based, if you have to, if you can, using that to drive patients into MRD negativity and keep them in remission for a longer time and get the maximum benefit out of it, that is possible. But the caveat is the side effects, particularly the unknown parts of it, the sudden death, the cardiovascular risks. And there are some suggestions from pooled analysis, albeit in small settings. For example, the Endeavor, Clarion, all of them have had Asian subgroup analysis that have been published. And there is some suggestion that in Asians, at least, there is possibly a higher risk of cardiovascular risk when we use higher doses of carfilzomib for a longer time. Now, I'm not sure why that is the case. We have our self-owned published, quite a few cases of carfilzomib-induced TMAs, some of whom, present with significant thromboembolic events, but some which are just, textbook microangiopathic hemolytic anemia and thrombotic microangiopathies only. And they don't have anything else. They have quite significant thrombocytopenia. They have clear evidence of hemolysis with elevated LDH. They have hemolysis when you look at the blood film. And in most of these patients, we are not able to re-challenge them with carfilzomib. So one has to take this, with a pinch of salt. And as I mentioned, when I take all this into context and then go back and say, who are those patients that I would employ this kind of strategy? So I would probably say patients with, very high risk chromosomal abnormalities, who can afford and can tolerate the carfilzomib in a quadruplet, albeit with dose reduction of lenalidomide if you have to, is transplant eligible, and then can carry on with the DARA plus the len if they can. Then those are probably the patients I would use this regimen in. And as I mentioned, it will be quite interesting, and this is one of my key questions that I will be, this next trial that we are doing under the auspices of IMF and Asian Myeloma Network. We use IRD, isatuximab plus lenalidomide and dex in transplant ineligible patients. And we use stringent CR as the primary endpoint, but one of our key secondary endpoints is the percentage of MRD resurgence in patients. And the construct is very similar to MASTER. We do 6 monthly MRD measurements. And one of the things we have mandated in the protocol, if patients only have MRD resurgence, the patients go back on the same treatment. And we hope to show that at least a good proportion of patients can be pushed back into MRD negativity just because they were off treatment, their MRD came back, we're giving them the same treatment. So what you're doing there is lengthening the PFS1 without having to resort to another drug, another new drug. We know this regimen they can tolerate. this regimen they can respond to. That is how they ended up in getting that MRD in the first instance. So we're just lengthening that PFS1 without having to use another combination, therapy for them. So hopefully, the MASTER-2 concept also that you showed is very interesting. Two different concepts of using, bispecific in and out, as well as the usefulness of transplant versus 3 cycles of Dara-VRd. I would think that the first part of that is designed, although it is probably not mentioned as such, is probably for the standard risk myeloma patients. And the second part, by design, I think you are going to have more of the standard risk patients falling into the first part, and by design, you're going to have more of the patients with 1 or 2 significant high risk myeloma patients falling into the second group. So it will be quite interesting to see the MASTER-2 when the results come out. So maybe I stop there and pass it over to Dr. Joseph John.
Thank you, Dr. Chandramouli. So, thank you, Rizwan. He had taken us through a nice disposition of the whole thing, and Dr. Chandramouli has given a lot of critical remarks on that. And so, though I agree with almost everything both of you have said, it's good to have some discussion and the differences there. And my entire viewpoint would be from standard terms of reference in our mind, which is VRd, autologous transplant, and LEN maintenance. And if you were to add on to the DARA quadruplet therapy, how much value would it add? We discussed about safety and efficacy almost all the time. We need to also look at the value, which is value added, which is the cost and the time associated with that. So here we have a regimen of 4 cycles of Dara-VRd plus 4 plus 4, 16 cycles, 12 cycles plus autologous sandwich between them. As compared to VRd with auto, maybe 1 or 2 consolidations followed by a LEN maintenance indefinite. And the hard endpoint we are trying to achieve is MRD negativity as a surrogate endpoint. And the hard endpoint is the PFS as of now, and treatment-free remission in terms of the quality of life we want to add to that. And we have shown that it is only 50%. Then it comes to the point where how much of MRD negativity can it add by replacing VRd auto LEN? And if you look at the previous studies, he has also alluded to that in his initial discussion, which is about 60%. So VRd with auto, we are able to hit 60% MRD negativity. And this additional value is now 10% on an average. And with double hit, it is ultra high risk is not going to add anymore. So 70 to 80% you can say MRD negativity this. So now we are comparing between a VRd into say 3 blocks. I'm taking 2 more consolidations after auto in VRd, but it is not the same. With ASCT, 1 4-block VRd and 1 autologous, we are hitting about 70%, 60%, 50 to 60% MRD negativity. The CR lag to the MRD negativity has not been changed, even in Dara-VRd. That he mentioned about 7 probable causes. Let's not go into that. All we are looking now is how much is the value added of achieving an MRD negativity by this. It is proven that double hit or ultra high risk is not going to help at all, even if you know upfront. And that is why about 1 week ago, we have a publication on a salvage, on a tandem transplant in those for consolidating with Dara-KRd auto with the tandem transplant. Even that has only shown a marginal improvement there with a lot of morbidity and associated. So I would differ there, saying that I would use this even in a double hit or ultra high risk. Now we are looking at the cost. If you do a random cost in India, it is about 80 lakhs rupees in a span of 1.5 years to spend for Dara-KRd the way it is set. So for an intent of a 50% transplant-free remission, I am going to offer a treatment which is 80 lakhs rupees with a 50% chance of treatment-free remission and a 10 to 20% advantage of MRD negative, as compared to 10 lakhs for a VRd auto with indefinite LEN. Okay, it is like hypertension, diabetes. Any chronic disease we are looking at is like a CML now with the treatment-free remission. So to me, though KRD is longing to come in, DARA KRD longing to find an indication to be used upfront, probably it has not found a place in my heart at least when I have to offer it to some patients, because it is only for standard risk and one high risk we can technically offer this. We have better regimens for that now. So because of short of time and less of time for arguments and debates on this, I would have loved to have some rebuttals on my thoughts here from Rizwan or Dr. Chandra. Maybe one line we can do a rebuttal on what I said, and then we can start the
No, I
eagle-eye
don't have anything
competition.
to rebut. Actually, I completely agree with what you've said. I was going to say, it doesn't found place in your heart and any of the regulatory agencies either. That's why carfilzomib has not been approved anywhere. So, to be honest, I know we did the carfilzomib cyclophosphamide dex trial in the first line, but I do not use carfilzomib as first line in any of the patients, including the high risk patients, because it's just, we do know that patients who don't respond or who progress on Velcade do respond to carfilzomib. We don't necessarily know the other way around works. So wasting what is a very good drug in bortezomib by not using it in first line, whether you want to use it as a triplet or quadruplet, it's there are arguments for and against. But I think to not use it at all and use carfilzomib straight away in first line, it's not something that I do and not something that I would vote for.
Sure. Thank you so much. For want of time, I'll hand over to Dr. Uday for the eagle-eye competition announcement and declare the prize winner to the video to be played.
Sir, good evening, sir. So I would like Sumit to take it on. Sumit is handling today's meeting. So.
Sure. Thank you, Sumit.
Good evening, sir. Am I audible, visible? Nirav, am I
Yes.
audible, visible?
Yes, sir. Yes. Please
Go
ahead,
ahead.
Okay. So thank you, Team Image. This time, eagle-eye competition May 2024 was based on a journal scan article, which was intensifying treatment in PET-positive myeloma patients after upfront autologous stem cell transplantation. This study was from the Nordic Myeloma Study Group. Next slide, Nirav. So that's for the journal scan article on which we received commentaries as follows. Next slide. We plasma cell dysplasias, which is selected by the myeloma experts. We asked students or any faculty who is interested in plasma cell dysplasias, irrespective of position, to send a commentary or critical analysis of 175 words before a deadline to us. The best commentary is selected by blinded reviewers, and the gain is that the winner gets a journal scan presentation in front of an august audience, along with a certificate of credit hours and vouchers worth ₹5,000. Next slide. So the purpose is that all of us should read the latest articles on plasma cell dysplasias. We should learn the art of critical appraisal, refine the art of scanning any article. This will promote us writing more letters to editors and obviously get an opportunity to present in front of a very good audience. This will also generate inter-institutional competition. Next slide. So the basic rules for analysis of any commentary is that anyone who has written should stick to the word limit, be clear, and still convey a critical analysis in a very good manner. They should also concentrate on the methodology and statistics. Multiple variables are analyzed as written on the left-hand side, and this also includes not only the abstract, but the author's core assumptions, along with the word count, errors in author's interpretations, some over and underemphasized ideas, statistical methods, and references to generate a final score. Next slide. This time, the winner for the best commentary is Dr. Nishant Sinha. He's a DM resident of medical oncology, third year at AIIMS Rishikesh. So congratulations, Dr. Nishant Sinha. I hereby request Meera from Mice Ideas to play the video of the best commentary.
Good evening, everyone. Thank you for this opportunity. Today, I'm going to present this article, which is intensifying treatment in PET positive multiple myeloma patient after upfront autologous stem cell transplantation. It was studied by Jacob Norberg and his colleagues and was published in 2023 Leukemia Journal and the DOI as provided. We know that multiple myeloma is a heterogeneous disease, and most receiving the modern therapy with the autologous stem cell transplantation do well, but some patient still relapses. Identifying those patients with high risk of relapse post-transplantation is crucial for the treatment adjustment and long-term survivorship. PET-CT imaging is an excellent modality and works well alongside of MRD analysis. Patient who test positive for PET scan post-ASCT tends to do poorer in long run. The KRD regimen shown to be promising results of myeloma treatment without compromising the quality of life. It could potentially convert the PET positive patient post-ASCT to PET negative and bring about a long-term survivorship. This study aimed to investigate a response adapted treatment strategy post-transplant using PET imaging and impact of the same in the quality of life in the KRD consolidation. A methodology. It's one investigators initiated prospective multi-center non-randomized phase 2 study done by the Nordic Myeloma Group in the 6 centers in Norway, Denmark, and the Portugal from April 2018 to September 2021. They included patients above 18 years of age with a good ECOG PS and a good marrow reserve and newly diagnosed multiple myeloma, which is started on the standard VRD, VCT, and VTD inductions, followed by the ACT consolidation. They excluded the patients who were already on the consolidations, any previous exposure of carfilzomib, patients more than 1 year of induction, expected survivorship of less than 6 months on patients on severe cardiac diseases, patients who were found to have HIV positive status or active hepatitis B, C infections, other malignancies, and the diseases other plasma dyscrasia than the multiple myeloma. The methodology, the consort with some details, about 159 patients were scanned and they were provided the PET scan. With the baseline PET scan, the PET scan was done based upon the impetus guidelines or the criteria which looked into the bone marrow metabolism, number and site of focal bone lesions and active lytic lesions, fractures and presence of site of medullary and extramedullary and paramedullary diseases. The FDG avidity was scored based upon the dual score, and a score more than 4 are considered to be positive. Out of 159 screened patients, 53 were found to have PET positive. Out of 53 patients, 50 patients were included and they were started the KRD regimen. Out of 50 patients, 1 patient withdrew the consent and 1 patient progressed while therapy, and 48 patients completed the planned cycles. And the patients after completion of the 4th cycle of KRD was given the response assessment about 1 month completion of the last cycle. The patient was also provided with MRD using the NGF at the baseline and after the completion of the 4 cycles of KRD consolidation. The patients were provided with the standard KRD regimen as provided in the box. With the 28-day cycles, about 4 cycles were given. The quality of life assessment was done by the various questionnaires given here, and the questionnaire was asked at the day 1 and day 15 of screening, day 1 and day 15 of every cycle, and 1 month and 3 months post completion of the cycle 4. The primary endpoint of study was to proportion of patient converting from PET positive to PET negative, and second endpoint was the correlation between the PET results and MRD dynamics by intra-patient comparisons. The results. The first table is the baseline characteristics in the patient in the patient of the PET negative group and the PET positive group. The both populations were well distributed in terms of the various parameters given here. It was found that about 82% patients, that is maximum of all, were given the VRD induction, and the median time from ASCT to screening PET was 146 days. Patients who were PET positive at screening were found to have higher ISS score as well as high risk cytogenetics and having received the VCD induction as VCD as their inductions. But all these differences were statistically not significant. The second table showed that after giving the KRD consolidation, how many patients actually have a positive PET positive conversion to a PET negative, PET positive to PET negative conversion. It was seen that about 33% patients were converted to PET negative, and numerically the patients who were given VRD induction were having higher conversion from the PET positive to PET negative than those given with other regimen, specifically VCD. But again, the differences were not statistically significant. No other factor actually had any impact on the PET positive to negative conversion rate. The MRD status. So about 47% patients converted from MRD positive to MRD negative. And after the KRD consolidation, about 78% patients were MRD negative. And patients who were MRD negative before KRD consolidations numerically have higher chances of converting from PET positive to PET negative status than those who were baseline MRD positive. 1 patient who progressed on KRD was MRD positive at the baseline. Now coming to safety profile, a total of 50 patients received at least 1 cycle of study. That means everybody at least received 1 cycle of KRD. None of the deaths occurred in the KRD arm, and the KRD arm was not stopped in any of the patient because of adverse events. 1 patient was stopped because of the progression on KRD. And a total of 28 serious adverse events were seen in about 40% of patients, including 25 treatment emergent severe adverse events into 18 patients. And most common were infection and DVT. Treatment emergent serious adverse events reported 1 patient, which includes atrial fibrillations, bleeding, acute renal injuries, and hypokalemia. PET at screening detected another cancers in 2 patients, one with thyroid cancers, one with malignant melanoma. PET after treatment detected pulmonary cancer in 1 patient, and addition of 1 patient developed malignant melanoma 3 months following the KRD treatment. Now coming to quality of life, the questionnaire was completed about 90% of patients, and it was reported that at the day 15 of the cycle 3 and cycle 4, patient had the poorest quality of life and maximum dip in the curve, as we can see in the given curve. So conclusion and comments from my end. The strength of the study. It's a simple study and easily plausible. The observations were comparable with other parallel studies of Jemami et al. And the Moru et al. And promising results of PET combined MRD is seen there. That is, the combining imaging and bone marrow based MRD analysis could be advantageous in clinical trials, future clinical trials, especially in trials evaluating the response to treatment. What are the weakness of the studies? It's a non-randomized study. It's a phase 2 study. The sample size is quite small. The OS benefits we do not know of the conversion from positive to OS from the positive to negative PET. The differences we see in the various tables are not statistically significant. Only Nordic population groups were included. Now, there is a lack of standardization of PET in the myeloma patients. Over treatment of MRD negative patients, those who are MRD negative, consolidating them with KRD on the based upon the PET positivity. Is it an over treatment? Now, using the carfilzomib, which is strong second line agent, into the first line agent as a consolidation for the based upon the PET positive status. How wise it is that? What is the projectability of the same in LMIC country like India? The time frame for the first PET to be done post ASCT is not standardized. The detailed quality of life assessment at third and the fourth cycle, the day 15, we do not have much idea into it. So finally, concluding the same, the study shows that the 4 cycles of KRD consolidation treatment after ASCT in patients with positive PET were able to convert a clinically significant proportion of patients in PET negative. The study also confirms the previous studies showing that the PET complements blood and bone marrow based response assessment using NGF. PET performed after ASCT can detect the residual disease that is difficult to detect in other methods. Thank you.
Thank you, Nishant, for a lucid presentation. I request Nirav to share the slides again. Right. So it is quiz time now. As usual, we do have 5 questions, 2 on the journal club, 2 on journal scan, and 1 on trivia, and we'll go through the quiz, which is the most interesting part of this webinar. Next slide, please. Next slide. So as I mentioned, 5 questions, 2 on journal club, 2 on journal scan. We start with the first question. Now we can go on to the next slide. So each question will have a time slot of 30 seconds. This first question is, which of the following statements is incorrect regarding the CONPET study? Option A, PET results were considered positive or negative using the impetus criteria. Option B, PET was considered positive if the Diogo score was 4 or higher. Option C, patients with new lesions or an increase in lesions meeting the IMWG criteria for progression were included. Option D, 1/3 who had PET positive after ASCT and 1/3 of those PET positive became PET negative after 4 cycles of KRD consolidation. This was a journal scan article. So time to move on to the next question. Next slide. What was the target dose and schedule of carfilzomib used in the CONPET study? Option 36 mg per meter square twice weekly. Option B, 45 per meter square twice weekly. Option C, per square once weekly. And option D, 70 per meter square once weekly. This was again the journal scan article with Dr. Nishant presented. We did talk briefly on carfilzomib scheduling while discussing the German club article. Next question. Which of the following statements about master trial is incorrect? This was discussed in detail by our national and international reviewers. A study was designed to include patients with high-risk cytogenetics like 4, 14, 14, 16, and 17p deletion. B, primary endpoint was achievement of MRD negativity because assessed by next generation flow cytometry, and cutoff of 10 power -5 was considered MRD negative. C, patients who received up to 1 cycle of VCD were included. D, there was no upper age limit and no restriction in terms of hematological parameters, which is incorrect. Next question. Which of the following statements again regarding the results of master trial are incorrect? This is regarding the results. Approximately 70% received MRD of less than 10 power minus per 2 consecutive assessments, and 63% have sustained MRD negativity. Option B, after stopping treatment, previous cumulative incidence of progression in 2+ HRCAs was 50%. A landmark analysis at post-induction time point found that processes with MRD positive impaired PFS in us. And last option, those required 8 cycles of DARA-TID consolidation to reach MRD sure. There is no progression was higher compared to others. The last question. Is the most appropriate use of the test below for a patient of myeloma on therapy? You have a here. The first 4 lanes are numbers of patient samples. N is positive control and C2 is negative control. So A is to solve the cross-match problem for patients on DARA. B, blood grouping problem for patients on DARA. And C and D similar options for patients on elotuzumab. Pick the most appropriate use of the test. Time is up. Next slide. So it's time that we declare the answers for the questions. Nirav, can I go on to the answers?
Yes, sir.
So the first question, which are the following is about CONPET study that the journal scan article is incorrect. The correct answer was option C, patients with new lesions or an increase in lesions meeting the criteria for progression were actually excluded from the study, and all others A, B, and D are actually correct. Next. So coming to question 2, the dose and schedule of carfilzomib in the Nordic myeloma study group study, that is the CONPET study, was 36 per meter square twice weekly, whereas in the master trial it was 56 per meter square once weekly. So the correct option for this question was option A. Next. So we move on to answer 3. Which of the following statements or master trial is incorrect? So it was enriched for high-risk abnormalities like 14, 14, 16, and 17p deletion. We also included chromosome 1 and 14, 20 later as a post-hoc analysis, but that was not the primary inclusion in the study methodology. Option B was, yes, the first half of the statement is correct, that primary endpoint was MRD negativity, but it was assessed by next generation sequencing by closely and not by flow cytometry. So option B is the incorrect statement here. Both option C and option D are actually correct statements. So the answer for question 3 is option B. Next slide. Coming to answer 4. Again, regarding master trial, which is incorrect. As Dr. Rizwan beautifully showed, that a landmark analysis that starting at post-induction time point and starting at post-ACT time point, even the patients were MRD positive did not impair the survival. And probably because those who were MRD positive did receive an intensive treatment of a quadruplet treatment like DARA-TID. Probably that is why. All of the options A, B, and D are correct. For option D, it is important that those who require a longer time to reach MRD sure or to reach a treatment-free observation time point, the risk of progression was higher than those participants who reached that respective time point much earlier. For example, say after autologous stem cell transplant. So the correct answer here is option C. Coming to the last question. Answer 5. So this is DTT means dithiothretol. This is basically an enzyme to cleave off the CD38 on the reagent RBCs because the daratumumab leads to a positive indirect home stress, which creates a problem for cross-matching, especially when you have to give these patients who have previously treated with daratumumab for further blood transfusions. So dithiothretol is an agent which cleaves off the CD38 from the reagent RBCs and helps us in solving this cross-matching problem. So the correct answer here is to solve the cross-match problem for patients on anti-CD38 therapies like daratumumab. Elotuzumab is anti-SLAM F7 and it is not expressed on the RBC, so that is why it is not an issue with lebrozumab. Next. So that's it with respect to the answers. So Neeraj, do we have the winner of the quiz?
Sir, Dr. Sanjeev from SGPGI Lucknow.
Oh, Dr. Sanjeev from SGPGI, congratulations. It's an honor for you to be the winner. You will get your vouchers from Image shortly. And thank you for all the national and international reviewers who participated here. The date of the next Journal Club and Journal Scan is on 27th of June, and the appropriate article for both Journal Club and Journal Scan will be released shortly. Over to you.
Thank you, Dr. Sumit, and Dr. Chandramouli had to leave. And thank you, Dr. Rizwan, for this entertaining day in the evening of the Journal Club, the thoughts, and the eagle eye and the quiz. So thank you, everybody. And before we wind up, I would hand over this to Dr. Uday for the closing remarks. And we have Dr. Hari and Dr. Reena Nair also joined us.
Thank you, sir. Any comments from Reena ma'am or Hari, sir, please?
No, it's been extensively discussed, Uday, and pretty complex, but it is just gives us, I mean, both the studies actually gives us a way, just gives us a slight idea as to whether there are alternatives that can be approached, that's all. But it can never, I don't think, as was in the discussion, that anything can come as going to be widely implemented through studies.
So, thank you, sir. Thanks for the remarks. And I would like to thank Joseph Jones, sir, the Complete Image Executive Committee, Dr. Sumit, who conducted the event today, Dr. Rizwan for presenting, and Dr. Molly for participating. And I would like to thank Mice Ideas for being a partner for this event for last 20 months now. So the next one is going to be the 21st Journal Club the next month, which is going to be on 27th of June. We'll be releasing the articles in the next 7 days. Thank you all, and have a great evening.
Thank you.
Thank you.